the University of Minnesota, and AR-v7 is of my translational interest. So, I think there's a problem with the cursor here. Can we move to the next slide, please? All right. So, when I think of what kind of tests for CPRC are we looking for, I think of 6 domains. And those are listed up here. And I hope that by the end of my talk here, I'll be able to convince the group that AR-v7 diagnostic testing has been successful in meeting several of these domains. So just a quick recap of the androgen receptor, the gene itself. So this is the full-length androgen receptor that contains the 8 exons. And then this is not working. So this is the androgen receptor variant that was identified about 10 years ago. And I'm proud to say that University of Minnesota has played a big role in elucidating the biology of androgen receptor variant 7 and many more. So the main thing that this receptor is missing now is the ligand binding domain, and it's independent of androgen stimulation at this point. Could we, I think I'm facing some presentation issues here. All right. So here are the couple of commercially available AR-v7 assays. And what I'm going to emphasize on is these are 2 different technologies that have come to the same conclusion in multiple different studies. And so that supports why AR-v7's biology is pertinent to our field. I'm still having some difficulty here. I think it may just be the presentation that's causing the problem. But
just say next slide.
Next slide. All right. Yeah. So this is the mechanistic model that's we've come across after about a decade of research. As been mentioned, AR amplification is the main driver behind a lot of these variants, and that's. But as more and more of these variants accumulate in the cell, there is growing data that the homodimerization and heterodimerization using AR variant drives resistance to anti-androgen therapy. There are a lot of unsettled questions here. And one of them is what's the relationship between androgen receptor variant 7 and full length? Which is more important? Going back to Dr. Sawyer's paper from 2010, it clearly showed that androgen receptor variants do not function in absence of androgen reception amplification, but subsequent data has shown that V7 by itself could suffice even in the presence of the full-length AR. So how common is AR-v7? There's 2 major studies that have shown the same result. And these are both prospective cohorts of about 200 patients each. In untreated patients, it's about 1 in 10 patients with AR-v7. In in second line, it's about 20%, and then in third line, it's 30 to 35%. Question becomes, is it a predictor of response? So far, the answer to these specific questions is no. Docetaxel mostly no. Cabazitaxel definitely no. And some of the novel therapies that maybe Dr. Alamkal will discuss later on in the meeting, androgen receptor targeting therapy, are likely to be no as well. There are other therapies that are going to be important, including cyclin CDK4/6 inhibition, that could be predisposed by presence of AR-v7. So I think this is the main question. Is AR-v7 a predictor of resistance? So this is the largest cohort of prospectively analyzed prostate biopsy specimens from 202 patients at Johns Hopkins. And as you can see here, patients with negative CTC, most of them have a response, which is what you would expect. If they have positive CTC but negative AR-v7, they still have decent amount of response. But when they have AR-v7 positive CTCs, the response rate dramatically drops. And I'm going to go back to that subset of patients who still had a response. That's about 10%, 15% of patients. And I'm going to talk about them. This is the data from Sloan, and it pretty much shows the same thing. In first line, there is less AR-v7 and much more frequent responses, and which diminishes as the tumor gets exposed to most treatments. I'm sorry, I'm not doing this by myself. It's alive. Uh, so AR-v7 has also in three prospective studies and one large retrospective study has shown to be prognostic. Uh, and this is actually one of them. And as you can clearly see, presence of AR-v7 CTC decreases the likelihood from going from an overall survival of 13.9 months to 3.2 months, which is an odds ratio or hazard ratio of 4, which is substantial. Again, shown in a completely different cohort, completely different technology behind this, looking at the same biomarker, clearly shows that regardless of patient-specific risk factors, there is decreased progression-free and decreased overall survival with AR-v7. Brings me to the one prospective randomized control trial, the ARMOR-3 SV, enzalutamide versus galadorone. Again, these were untreated patients, and 8% of those had AR-v7 positive at baseline. Now, I picked up these slides from Dr. Taplin's ASCO meeting, so some of this data is still maturing. But you can see here that the majority of patients untreated are negative for AR-v7. When they are positive, these patients have worse disease biology and short time to metastases. As you can see, some people look at this table and say that these patients are still responding. There's almost 40% response rate, PSA-based response rate in this trial. The problem is not PSA response. The problem is there is no change in radiographic progression-free survival. So yes, the PSA drops, but no, it does not matter. So I'm going to take the luxury of a little bit going out on a limb here, but I think that a decade of research on AR-v7 has shown enough data to suggest that these variants alter disease biology, that they're associated with a whole host of poor clinical factors, and that they increase in prevalence as you treat the patients roughly by 10% with each line of therapy. And 1 in 3 will have an AR-v7 or some variant after exposure to at least abiraterone or enzalutamide. Right now, I cannot recommend to use this in untreated patients. We just don't have mature enough progression-free and overall survival data. But it is clearly the AR-v7 positivity in CTC in 2 different assays, again, 2 different technologies, have shown that there is a lack of durable response to enzalutamide and abiraterone after progression on first-line novel anti-androgen. There is a remarkably shorter progression-free and overall survival. And this is despite, so even if you give the patient taxane therapy, their progression-free survival is still shorter than a patient who doesn't have AR-v7. And then I would go out on a limb here and say that I think after, again, a decade of research, we've reached a point in AR-v7 where this assay is relevant, is ready to be used in clinical practice. It makes sense, especially and right now, to use it after the patient has progressed on abiraterone or enzalutamide to choose what to do next. Should you give somebody with AR-v7 positivity the second line novel anti-androgen, or should you go on to taxane or go on to one of the several therapies that are coming up? I would suggest that, or I would recommend that we choose something that does not have the same mechanism of action as the next line. And we certainly await the result of the prophecy trial to get more understanding of the disease biology, what happens with the AR-v7 and AR amplification. But with that, I would end my talk, and thank you so much. Dr. Petra?
So just, oh, I'm sorry, Dan. Yep.
We need to have more than one microphone between the three.
We need a bigger mic.
We need a bigger mic or something. So maybe two for Oliver. So the question really remains, is it the amplification of the androgen receptor that's driving the growth? Is it the AR-v7 causing an alternative activation of the signal transduction pathway, or something else? It's actually a two-pronged question. The second question, we will be provocative about the need for testing. So one could argue from a healthcare cost basis that you're spending $1,200 for this test around that area, and that empirically you could give enzalutamide or abiraterone fairly cheaply in a month's period of time and not waste the time of having the test done, and really come at the same conclusion after 4 weeks. So what advantage does the AR-v7 test give you in that situation?
I'm very glad you asked, and if I apologize, I had a slide about cost effectiveness. That is one of my favorite things to talk about. So there has been a study, and Johns Hopkins group did this. As long as the cost, it takes about 3 months. You expose the patient with AR-v7 for about 3 months before you see progression. So what the Hopkins group did is looked at the cost of any second-line novel anti-androgen for 3 months. That came out to be about $20,000. And when they compared that with the cost of the test, they came back and said that this saves you several $1 million. And that makes sense. And I think we could go back here a couple of slides and certainly show that data. But from cost effectiveness standpoint, these patients, even if they're responding to with PSA, so that's the curve. So the bottom, the curve B, is as long as the cost of the drug, the 3-month supply, is less than 10,000, it makes sense. It is cost effective to do the testing first.
But it really doesn't take 3 months. That's you can get a pretty good readout in 4 weeks with Enza. And so that no, not first line. Yeah. Yeah. I think he concluded the naive was not worth it. I mean, you look at Armor 3. I mean, it's just
because the yield is very low.
Yeah, it's just you screen, right. And it's rare.
Just knowing. Oh, I'm sorry. Go ahead.
No.
I forgot to.
And that, I don't have sufficient clinical experience to say that 4 weeks would be enough. I would say, in my practice, I've gone a little bit longer, but again, as long as there is a cost-benefit relationship, if you are spending $6,000 or more on this patient, it may be better or to do the test first. In my experience, whenever I've ordered it, the results have come back in a week. So it still saves some time.
The Epic Bioscience. Oh, Julie, you had a
No,
question.
that's okay. Go ahead.
Well, I was just going to say the Epic Biosciences test is looking at nuclear AR-v7 in CTCs, and theoretically at least should offer a higher specificity for biologically active or biologically relevant AR-v7. I actually don't know how much that test costs. I've never ordered it, but it is available now for a couple months. $1,200?
Yeah. So it's the full cost is $4,000, but average is $1,200 is what it is. And the answer is, performance-wise, these tests have been tested several times in 2 cohorts, and performance seems comparable.
So there's only so many options we have for our patients. And sometimes after enzalutamide, for example, the patient's fine. No pain. I mean, they're not fine. Their cancer is progressing, but they're not quite ready for taxanes. And just knowing that AR-v7 test is not perfect, that someone who has that mutation could still respond to abiraterone. I guess I want to know from your data, you circled it and said that they don't really have good radiographic response or improvement in survival. How many patients were there, and can you really say that with certainty?
Correct. So I actually called up Emmanuel before this talk and asked him that same question: is who are those 4 patients that, despite AR-v7 positivity, had PSA response more than 50%, drop in PSA more than 50%? The progression-free survival for those patients was still 3 months, 3.4 months. That's
So Chuck is goading me on a little bit to poll the crowd about how many, and I'll just say in the last 2 months, have ordered an AR-v7 test on any of their patients. Is anyone using the test that is now commercially available? I'm looking around the room. I don't see any hands up. I see one. I'm sorry. There's one hand up.
That's
There's one
certainly,
hand up.
I don't think that qualifies me to speak
I
here.
apologize. Yeah. So it could be that people have voted with their feet.
Agreed. And we spoke about this as well. If we had a targeted agent that this test could select for, we wouldn't be having this conversation. So if this was a predictive marker, it wouldn't be a problem. Or if we had, like Julie said, 5 other treatments in different types of mechanism of action, we wouldn't be having this conversation.
So if you were in charge of the protocol at the Fairview Health System in Minnesota, and you said to the docs out in the system, you can order this test for $1,200 and not waste unnecessary enzalutamide or abiraterone on patients who won't benefit from it. You have your cost data. It may not be us who make the decision. It may be something that payers ask us or not payers, but health systems start asking us to make. And that's actually a reasonable thing to think about.
I have a question, Arpit. So patients who have AR-v7, it's not like they will not respond to anti-androgens at all. I mean, the benefit may be a little smaller. And on another note, as you know, AR-v7 is just the tip of the iceberg. There's AR-v9.
Right.
Scott Deems and Manish Kohli's paper showed that AR-v9 predicts resistance to abiraterone. So are we just paying too much attention to AR-v7? Is this test really ready for prime time, as majority of people are still not using it because options are limited and you have to try everything for every patient at some point?
And that's the reason why there's a holdup. And yes, the AR-v9 story is evolving. So far, all the evidence is V7 and V9 go together. So if you're detecting AR variant, you're just as well selecting or showing that matches up, at least in basic science part of the AR variant story. I think it goes back to the same point. You're seeing a progression, a PSA response, which will not translate into survival advantage. The question is, are you happy with the PSA response? And if so, I think that's totally fine. But, sorry, go ahead.
So in relation to your PSA response and durability of response to abiraterone or enzalutamide, there's been this phenomenon noted by DeBono's group about giving dexamethasone or switching your steroids when a patient progresses on abiraterone. And I've seen some pretty dramatic responses and durable responses, in some cases more than a year in that situation. So what is the effect of dexamethasone on AR-v7? I mean, purportedly it's through a back channel of steroid synthesis. But is there an effect of corticosteroids on AR-v7 expression? And could that be an explanation why we see secondary responses?
So I recently sat in a really interesting talk, and I think Dr. Hahn talked a little bit about this, the promoters and the enhancers. This is where I think goes back to is with testosterone, you're shutting down that feedback mechanism. And so maybe that's the answer, is we have to look outside the AR gene to figure out why there's amplification, why there's responses despite AR variant presence. I think that may be the answer.
All right, we ought to get moving along. So we're going to turn it over to Dan, who's going to kind of moderate the next session.
Thanks.
Thank you.